So again, spoiler alert, I'm going to talk a little bit about what happens after they find her body, and they wind up, it takes them a long time, I think it was 19 days before they actually figured out where this woman was and what was going on, and they happened to find her in the most bizarre place. She was on top of the roof in one of the water canisters, one of the water containers on the top of the roof. And there's mystery surrounding how did she get there, how did she die, did someone put her there, etc., etc. But what was most interesting to me as the psychiatrist looking at this case was the medication list that was shown. So, of course, they're going to have an autopsy, they're going to do a toxicology report, they're going to figure out exactly what she had in her system, exactly what was going on prior to her death, and also try to come up with a cause of death, right? What happened to her. So going over the medication list first, I think that part's kind of interesting because, again, all we know now is she has a history of depression, she took some kind of psychiatric medication, she's from Canada, she's from Vancouver, Canada, she comes to Los Angeles, she's 21 years old, she's trying to travel on her own, kind of get out there in the world and do her own thing. So we don't really know too much about her psych history, and we don't know too much about the medication she was taking until we got the results back from the autopsy. So the medication list actually consisted of a bunch of different medications. So there was venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, commonly used to treat depression. Bupropion or Wellbutrin, norepinephrine dopamine reuptake inhibitor, commonly used to treat depression, also smoke cessation. Lamotrigine, which is a mood stabilizer, it's also known as Lamictal. Now this is one that we use commonly in bipolar depression, so kind of hint to what we're thinking might be her diagnosis. And quetiapine or Seroquel, which is an atypical antipsychotic, again commonly used to treat bipolar depression. So the first thing that stands out to me about this medication regimen is that it looks like polypharmacy to me, right? This looks like, she went to a doctor and they started like putting on different medications, trying things, maybe weren't getting the results that they were looking for, and just continued to add medications to her list as she went along, and she still wasn't getting, I guess, fully better or to an adequate level that was comfortable for the treating physician or the patient. Now, there's a lot of controversy surrounding whether or not somebody with bipolar disorder, even if it is bipolar depression and not like, say, a pure bipolar 1 mania. With bipolar depression, there's a lot of controversy whether or not you should even use venlafaxine or bupropion or any antidepressant medications with those patients. A lot of docs would probably say no, and they certainly would say no unless the person was already on a mood stabilizing agent first, right? So the idea behind a patient like this would be, maybe let's take the example from her list of lamotrigine. You'd want to titrate up the lamotrigine to an adequate dose so that she's getting some of those mood stabilizing benefits from it, and possibly even be using quetiapine at that point. And then if you're not getting any benefit from the mood stabilizer and the atypical antipsychotic, then you might consider adding the antidepressant because you might want to get that little extra boost. Now, of the two antidepressants that she has on, venlafaxine and bupropion actually has the most data to support its use, right? It has the most data to support its use in bipolar patients. It tends to be less likely to induce mania. It doesn't mean it can't do it, it just means it's less likely. So if I was going to choose, again, an antidepressant to use on a patient with a bipolar diagnosis, then that would maybe be one I would consider. But again, it's like third line in this medication regimen because the other medications are far more important. So a couple of other interesting things from those autopsy results. One, we know that the blood levels or serum levels of these drugs in her system were actually low. So she wasn't taking her medication, which is a common issue, and very, very common with bipolar patients, because bipolar patients tend to enjoy those episodes of mania and the episodes where, they do feel good. And they commonly have periods where if they're feeling good, they don't want to keep taking medication or feel like they don't need medication anymore. And so they take breaks from it. And then, of course, that leads to acute decompensation and results, in some cases, hospitalization and needing to restart the medication. So we know she probably either wasn't taking the medication or was taking it in much lower doses than she should have. So what we see here is a couple of things. One, she has a psychiatric history. 2, she most likely has a diagnosis of bipolar disorder from the medication, and they're most likely treating what appears to be a bipolar depression. She was on multiple medications, some which are indicated for bipolar depression, others which aren't necessarily indicated, namely the SSRIs. And we also know that she was most likely non-compliant with the medications, so it wouldn't be unreasonable to say that when that film was taken on the elevator, she was acutely decompensated at that point and potentially having psychotic symptoms, such as delusions or hallucinations. So at some point in the series, they actually talk to her sister, this woman's sister, and we find out some more of her past psychiatric history, which again I think is really relevant in this case and extremely important. So we find out that she's had prior hospitalizations, and that she has a history of non-compliance with medication, and that when she's non-compliant with her medication, she was known to get paranoid and to believe that people were following her or out to get her. So that's interesting data, right? Because we saw on the video that she was appearing to be paranoid, hiding in the corner of the elevator, jumping out, peering around the corner of the elevator, looking out, peering outside. So very, very strange, disorganized behavior, but it makes sense if the patient is experiencing a high degree of paranoia or paranoid delusions that someone is following them or out to get them. We also know from her psych history that she did have some depression, right, and was talking about it actively on the social media platform Tumblr, where she would post quite often. So she actually did so much social media posting that people got a very good idea of like what kind of person she was. And clearly from those posts, I could easily pick out like, hey, this is somebody that you'd have to watch. This is somebody that I would be worried about on a regular basis. Because the things she was saying and the ways that she was communicating on social media indicated to me that she was in distress a lot. And she was looking to social media for that support system, which obviously, we know social media isn't always the best place to find support groups, although at times it can be very helpful as well. So that I thought was quite interesting. We didn't hear anything about her having prior suicide attempts, but again, I would not doubt it based on what we knew about her. Knowing that she's had hospitalization, she's been decompensated, been paranoid, it wouldn't be surprising if she did have prior suicide attempts, and it wouldn't be surprising to me if they found out that they ruled the cause of death a suicide and not accidental drowning. So to wrap this video, I just want to say like some of the things that stand out to me that could have maybe been done differently. And of course, I'm Monday morning quarterbacking this thing. Obviously, we don't know what actually happened in the treatment. We don't know why things went the way they did, but I'll just explain some of the things that stood out to me. One is the medication regimen that we've already talked extensively about. I think there were some things that could have potentially been optimized and some medications that they should have reconsidered. And maybe this was a treatment-resistant case, right? But given her history of non-compliance, I suspect that one of the reasons why she wasn't improving more was because she wasn't really compliant with the medication and the treatment. So that brings me to my second point, right? My second point about this is that she would have definitely benefited from some psychoeducation, right? And possibly involving the family as well. So what I would do in a case like this is I would sit down and I would have an entire session just dedicated to talking to the patient about the diagnosis, explaining exactly what bipolar disorder is, and specifically bipolar depression, what to look out for, what are some of the common triggers, what are some of the common symptoms, right? Just really dive deep into the diagnosis and help the patient to understand exactly what they're going through so they can make more sense of it. So that would be the first place I would start, is talking about the diagnosis. After that, I would talk about the medications, and I would address at that point any concerns the patient may have. So if the patient has concerns about side effects, if they are experiencing specific side effects, what are their fears surrounding the medication? Like, what are they worried about might happen if they have to continue taking medication? Or what does it say about them as a person that they need to rely on medication to feel okay and to not be depressed? A lot of patients have apprehensions about that kind of thing, and a lot of patients feel shame, right, about having to take medication, and they really feel like it's a crutch and it's something they shouldn't need to do. So addressing any of those fears, addressing any of those concerns, addressing side effects, all very, very important. Then With that said, you could have also considered psychotherapy. So there's a couple of different things besides just the psychoeducation that you can do. You could do potentially social rhythm therapy and or cognitive behavioral therapy with this patient. CBT, although indicated, I would say it's more of a second line treatment for these patients because they generally have difficulty doing the homework, keeping up with things, and going through the processes that are required to do cognitive behavioral therapy work. However, psychotherapy may have benefited this patient, and who knows, she may have been doing it. Also addressing other factors like cultural factors. So